So the first thing to know about OCD is what an O is and what a C is, right? So
yes.
O's are thoughts, so persistently recurring thoughts, impulses, or images that are experienced as intrusive, inappropriate, and distressing, and they're not simply excessive worries about realistic problems. Okay, so that's the first part. Then the second part is the C's. So you can have an O's and you can have C's, but OCD has both. So compulsions are repetitive behaviors or mental acts. So it doesn't have to be happening like counting your head would count, that a person feels driven to perform according to a rigidly applied rule in order to reduce distress or to prevent some dreaded outcome, even though it's not realistically going to reduce the outcome. Okay, so that's what the O's and the C's are. And this isn't like an incredibly prevalent problem. It's overall about 1% in the adolescent population. And since we have a bunch of doctors on the call here, I hope all of you have some O's and C's, because normal obsessions and compulsions are normal, and they actually serve really important functions to keep you doing what you should be doing, right? It reminds me a little bit about your superego, right? That it's out there telling you that you should be doing something. And the normal OC behaviors are similar in both form and content to obsessive-compulsive disorder. As for most mental health disorders, we all have a little bit of it, but when it's more frequent, more intense, or is having consequences on impacting on your life, that's when it starts to be called a disorder. So in people who are considered normal, these obsessive and compulsive behaviors are rarer, they're briefer, they're more easily dismissed, like you can say, okay, I don't have to do that. They're less vivid. They don't feel like they're coming from outside of yourself. That's called ego alien. And they are less uncomfortable, and they're less likely to make you try to do something about them to get them to go away. So the fact is that there are normal stages of the development of obsessive and compulsive behavior that are really good to know about. And actually, this first one, I wish Emily were here so I could give her credit for alerting me to this, but it's been really valuable to me personally to know that 2/3 of preschool children have really striking obsessive and compulsive behaviors. They like things to be the same. They want the right bowl for their cereal. They want to do things symmetrically, like if you use your right hand, you should use your left hand, or if I have the fork on the right, I want the fork on the spoon. The fork on the left, I want the spoon on the right. And they have this sense that they want things to be just so, and they get upset if they can't have it that way. And these behaviors are most intense between age 2 and 4. Isn't that interesting? So if you think about the little kids you know avoiding the crack in the sidewalk, it's kind of like a joke, isn't it? Step over the crack or break your mother's back. That those little things that happen are actually really normal. And it's said that having these little habits actually help people with their anxiety, particularly their separation anxiety, which is pretty high from age 2 to 4. And then when you get into school age, kids play repetitive games. They have to be done just so. They have rituals and they have activities, and they actually enjoy these little rituals, but they can stop them when they need to, and they don't get in the way. And then in adolescence, sometimes adolescents get to the point, and I think my classic kind of example of normal obsessions is the move to become a vegetarian, which so often happens in adolescence, and they absolutely won't touch any animal products or something like that. And that also can be completely normal. And by the way, all of these behaviors come out more when the kid is stressed or under some kind of pressure. For example, the pressure for toilet training is kind of like we're trying to induce a little obsessive compulsive behavior when we're toilet training kids. Think about it, right? Don't put your fingers in that, and don't poop in your pants, and don't do it here, and don't do it there, as well as in controlling aggression. So when parents are putting kids under a lot of pressure for those things, sometimes it kind of goes overboard a little bit, and the kid develops obsessive compulsive kinds of behaviors. And here are some really interesting statistics about people who are considered to be normal and what percentage of those people have, or of those people who report these things, what kinds of things, and these are adolescents primarily, have these kinds of behaviors. So look at that. 29% do hoarding behaviors, and 27% do repetitive actions, and 34% have ritualized routines, and 49% are orderly. Sometimes we wish they were more orderly, right, when they're teenagers. But 72% have times of extreme neatness. Now, by the way, people normally don't have all of these at the same time. Even if they have obsessive-compulsive disorder, the symptoms vary over time. So back to the question of when is it disorder? Now, Laura's kid is clearly a disorder, and we'll talk about that in just a second why. So the criteria are that the presence of these obsessions or compulsions cause attempts to reduce them, and they cause impairment in terms of marked distress or time consumed, more than an hour a day, or significant interference with daily routine or academic or social functioning. That's Laura's kid, right, because it's getting in the way at home and it's getting in the way at school. And then you're supposed to give some specifiers. You know how the DSM is. You can say they have good insight into it, poor insight into it, or absent insight into it. And you also want to document whether they have tics or not. By the way, does this kid have tics, Laura?
No. She had some finger picking, but that's disappeared. But that was really, it didn't manifest any other pattern of tics. But there was some picking for a while. I'm not sure if it was stimulant related or not.
Got it. Okay. You didn't mention ADHD. I assume she has ADHD.
I'm sorry, I forgot to say that.
Yeah, which, as you know, can be pretty severe in fetal alcohol syndrome. And I'll talk about the comorbidity in just a second. So the presence or absence of tics is actually pretty important because they have different prediction to outcomes. So this is from the DSM-5. That's a really long list. Not better explained by. So in other words, it's not OCD if it's one of these things. And that pretty much looks like the DSM, doesn't it? So if you think about it, all of these have symptoms that can look a lot like the worries of OCD that I just described. So you can have general worries, you can worry about your body, you can be hoarding, you can have hair pulling, you can be picking your skin, you can have stereotype movements, you can have an eating disorder, you can have substance-related and addictive disorders, you can have anxiety about an illness or paraphilias that make you think a lot about sexual things, you can have disruptive impulse and conduct disorders like ADHD, you can have depression where you're ruminating on sad thoughts that may look like an obsession, but that doesn't count as an obsession. You can have schizophrenia, spectrum, or psychosis, and you can have autism. And if you have those things, then you don't have OCD. So just keep that one in mind. So here's an interesting fact that I never knew. So I always learn a lot getting ready to talk to you guys, and that is OCD is among the 10 leading causes of disability in the world. Doesn't that kind of blow you away? What do you mean OCD is 10th? Well, because it has so much functional impact. So, you know, this is a brain disorder, so it occurs in the frontal corticostriatal thalamic circuits, and on MRI you can see abnormalities in those areas, cingulate cortex, basal ganglia, and the thalami. You can see different blood flow, and they look different in kids with early onset OCD versus late. It's genetic, so identical twins have higher concordance than dizygotic twins. There's a few chromosomes that are implicated. But here's some things that are very relevant on a day-to-day basis, because so far I'm not recommending an MRI, I'm not recommending chromosomes, but what you need to know is that in the childhood onset of OCD, first-degree relatives are tenfold more likely to have OCD than in the general population. And also, and this is very relevant to your case possibly, and that is early sexual or physical abuse raises the risk for OCD. So what's the course of this? Well, a third to a half have onset before 15. So there's two kinds of peaks to the onset of OCD. One of them is in pre-adolescence or adolescence, and the other one is in adulthood. So since we're pediatricians on this call, we're interested in childhood ones. Some kids present as early as 5, but the mean age is actually 10, and boys are more likely to have an earlier onset, and they're also more likely to have tics, whereas girls are more likely to have a pubertal onset.
Yeah.
So if you have onset in childhood, about 40% will lose their symptoms over years, but many or most don't. So that's kind of a sad state of affairs in a way, but in a way, I think it helps parents to say, we can't just let this wait and let this pass, because it probably won't just pass away. It's something that's going to go on, and although the symptoms come and go to some extent, most people with OCD have endorsed all of the common symptoms at some point in their course. And the last point on this slide I think is really important, and that is there's a fair amount of suicidal ideation, 50%, and 25% sometime attempt suicide. So now you can compare that to the general population, and the general population certainly isn't at zero, but that's higher than the attempts in this population. So the suicidal ideation in the general adolescent population is what? How much? It's about 25% of ideation, but the attempts are more like 10%, not 25%. So it's a big risk. Comorbidity means that the chances of this occurring in addition to OCD, right? Whereas differential diagnosis, which was in that longer list I gave you earlier, is if you have that other thing, then you've got to make sure that the symptoms aren't due to the other thing. So, but people who have OCD, between 33 and 50% have an anxiety disorder, and when you have one anxiety disorder, the chances are pretty high you'll have a second or third or fourth anxiety disorder. So, and here's the good news. I mean, not that doesn't sound like good news, right? But here's the good news, and that is the treatment is very similar, both the medication treatment and the therapy treatment. But you want to pay attention to both, because even though anxiety is often unrecognized, OCD is even more often unrecognized because the kids are kind of embarrassed about it, and it's like a secret, especially if they get it, that they shouldn't be doing this, and they often don't tell you about it. And so that's really an important thing to keep in mind. And as Laura's case points out, the OCD may be the main thing that's causing the dysfunction, more than the anxiety even. So 60% will have tics sometime in their lifetime, and they can be any kind, simple, mild, or transient tics, all the way through Tourette syndrome. And you all know to be thinking about Tourette's when you see OCD, because there's such high comorbidity between Tourette's and OCD. Mood disorders like depression, 20 to 75%. Attention problems, that would be your kid. Oppositional problems, that would be your kid, Laura, 33% and 43%. And also learning problems, so visual motor integration and visual memory, as well as executive functioning. So the fact that this kid has a learning disability, ADHD, and ODD shouldn't come as a huge surprise, because those things commonly go along with it. And of course, this stuff all gets in the way of living sort of a normal life. Now, let me point out that there's a separate thing called obsessive-compulsive personality disorder, which is not the same thing as OCD, but it co-occurs in about a quarter to a third of the cases. So how does this stuff get in your way? Well, how does it get us? So you can see that this causes social problems, family problems, if they seem weird enough or if they're afraid enough. For example, afraid of germs. They may actually never go out of, not go out of the house, or not be able to seek even medical care because they're afraid of germs in the medical facilities. 45% will have trouble with employment or sustaining a job. But the fact is, the college graduation rate, or the college attendance rate, I don't know about graduation, but college attendance is actually not significantly different from controls, which I think is kind of interesting, and I don't know which study that was. So I bet you guys are thinking about autism as you listen to this, and in fact, autism has similar symptoms to OCD, right? But the kids with autism are not distressed by their symptoms. In fact, they're often kind of relieved by their symptoms. We call it stimming sometimes, that they may obsess on certain things or have compulsive behaviors, because you don't always know what a kid with autism is thinking, right? So it may cause distress to the family, but it doesn't cause any distress to the kid. And so for that reason, it's not considered obsessive-compulsive disorder, although it may respond to the same treatments, in particular SSRIs. So it's really important to recognize this part of autism. So this is kind of rigid insistence on routines, makes it really hard for the families, in many cases of kids with autism. But keep in mind something that you probably know about your kid, which is there are high rates of obsessive-compulsive disorder in first-degree probands of autistic children, like her case, where there's a brother. Now, is that brother biologically related to her?
Yes.
Like her
I don't know
biological
if there's
brother?
consanguinity for him or not.
Yeah, interesting. So he has autism and she has OCD. Well, I'll go a little faster.
Right.
This is something really interesting, and that is because this seems to come from the basal ganglia, in many cases, things that affect the basal ganglia can cause OCD, like carbon monoxide poisoning, wasp stings, and post-viral encephalitis. But also Prader-Willi, high doses of stimulants, which it's possible was true for her because she's got fetal alcohol, so she probably needed high doses. Yeah. And you all have heard about Group A beta strep, which causes Sydenham's chorea, but also other kinds of medical problems, infectious diseases can spur on OCD just like strep can. So Lyme disease, celiac disease, thyroid disease, Kawasaki's disease can all make it start. And so even when PANDAS, that's pediatric autoimmune neurological disorders associated with strep, when you suspect that, it doesn't mean that you should do routine prophylaxis. Instead, you should treat intercurrent illnesses more aggressively and treat the OCD as well. So that's just the short form of that. So I mentioned the importance of tics. It turns out that about 30% will have tics, and those people are more likely to be boys, to have more aggressive imagery, to have earlier onset, and they also tend to be harder to treat with SSRIs. Whereas the ones without tics, which looks like it's her, are more likely to be girls. They're more likely to have obsessive worries and thinking about cleanliness and have later onset. So as I mentioned, the kids may not tell you about this, and the parents instead complain about temper tantrums, declining school performance, because kids are obsessing over doing their work a certain way. They dig a hole through the paper with their erasers. They're never satisfied with their results. That can be part of anxiety too, but it can be part of OCD. Food restrictions or skin picking can all be things that make the parent come in to see you when in fact you don't know and the parents don't know that the kid actually has OCD. So of course you have to ask the kid, the parents, and teachers. And what you're trying to figure out is, when does this happen? What are the symptoms? How often? How distressed are they? How hard do they try to get rid of it? And what degree of insight they have? And also whether they have compulsive acts to try to prevent some kind of feared outcome. And that'll be part of the treatment as well, because you'll hear in a minute that the cognitive behavioral therapy is part of the most effective treatment, and that if you can help them understand cognitively that what they're doing doesn't help prevent the outcome really, that's part of how they get to be able to let go of those compulsive behaviors. How much time is it taking up? Has to be at least an hour a day, as I mentioned before. And do they have tics? And then looking for other habits which might suggest trichotillomania or body dysmorphic disorder or something else that's not OCD. Of course, you want to know about their development, home and school problems, and the family history, but also how well the parents are tangled up with the symptoms. Now, in this case, the parents are very irritated by the symptoms, but they're having to accommodate to some extent, right, Laura?
Yep. Significant.
Right, and so it's a balancing act because the parents have learned how to survive, and sometimes they may learn to survive by giving the kid a pad of paper to rip up. I don't know what they've done to make it possible to get out the door in the morning, but sometimes the strategies or the anger that are expressing about those strategies actually make matters worse. So these are some of the tools that can be used to monitor OCD, and I'm going to show you this one later, but I don't have to show it to you right now. That's the Yale-Brown Obsessive Compulsive Scale, which is in CHADIS, and it's there as either a parent tool or, a tool for adolescents to self-administer, or you can use it as a clinician and score it from CHADIS. So let's talk about treatment. So if the child is not distressed and it's not causing impairment in their life, you actually don't need to treat it. You can just monitor it over time. Keep in mind, if there's no distress and there's no impairment, what do we call that? We call it normal, right? But you do So if it's stress-related, like there's a specific stress, like sexual abuse or physical abuse or toilet training stress, that might be a time where support or therapy about reducing stress may be all that's needed. In every case, you want people to have education. We call it psychoeducation, teaching them about this thing and destigmatizing it and reframing it for the kid as well as for the parent. This is something your brain is doing to you. Let's give it a name to make it more objective. Let's call it our paper fetish or whatever you want to call it, so that we can be on the same side in trying to get that paper fetish to quiet down. And getting the family to calm down and be supportive of the kid can be very important as well. There are support groups for this kind of thing. Okay, so let's say now it is OCD, and it's mild to moderate. Well, that's where the primary indication is for cognitive behavioral therapy. And there's a special branch of cognitive behavioral therapy that is proven that is the best evidence, and that's called exposure and response prevention. Now, those of you who've been in on these calls or know a lot about CBT know that this is part of all CBT, but this is a component of CBT for OCD that's most important. And basically, what you do is you figure out what their obsessive thoughts are about and what their compulsive behaviors are, and then you get that information, and then you, with the help of a therapist, expose them to that thing, but don't let them act on it. That's the response prevention part. And then they have to practice on their own. Now, this is very hard to do. So in other words, this therapy is stressful for people. So teaching them about relaxation and breathing control can help them to get through the training, the ERP training, and so can rewards. That can help them too. And if with a young kid, I might mention marks or points for them actually being able to get out the door with 50 pieces of paper instead of 55 pieces of paper, and then they would get rewarded for that improvement that they might have. Clearly, the best outcome from this kind of treatment is if they're cooperative and if they have compulsions that you can see, because if you can see it, you can monitor it and measure it and report it and work on it. Obsessive thoughts are much harder. Mm-hmm. And the younger the kid, the less able they are to actually report on their symptoms. So the effect size for this treatment is 1.45, which is okay. Now, if it's moderate to severe, then you want to talk about medicines. And the main medicines are serotonin reuptake inhibitors and in a combination with cognitive behavioral therapy. So it works the best when it's combined. You'll see that at the bottom of the slide there. So CBT alone has an effect size of 0.97. Sertraline alone, 0.67, but when you put them together, it's 1.4. So that was the POTS study, which is in the references if you're interested. So clomipramine is actually the most powerful medicine for OCD, but you can't use it until they're over 10. So she's closing in on it, Laura, if you're still there.
Yeah.
Being able to do that, and it takes a while to see progress. So you want to start low and go up slowly. You often see improvement by 5 weeks, and you can go as high as 3 milligrams per kilogram per day, but not higher than 5 milligrams per kilogram per day. And this is a medicine that can cause seizures. It can cause prolonged QTC. You've got to do EKGs on it. It can have anticholinergic side effects. So it's not trivial, but it's the most effective of the bunch. But it's not approved for younger kids, but these are. And these are other medicines that have shown to have effectiveness for OCD. So that's Prozac, Luvox, Zoloft, and clomipramine. So many of you may not feel comfortable with clomipramine, but you might be comfortable with Prozac. And you can use that. The study was in kids 6 to 12, but of course Prozac can be used for older than that as well. Starting out with about 1 milligram per kilogram per day. But you can, with liquid Prozac, even get down to 0.25 milligrams per day. And I've actually done that with younger kids, and they tolerate it much better if you start down there and go up slowly. Remember that when you stop Prozac, you still have an effect for 6 weeks. So if you have a bad effect, don't forget to tell the parents about that. And the improvement can go on for really over a year from once you've optimized the dose. Now, the next thing is some of the symptoms that you can get. side effects from Prozac and other SSRIs, including trouble with sleep. But by and large, Prozac is extremely well tolerated. And then you want to stick with it on an adequate dose. Try it for at least 3 months before you would change to a different SSRI or before you would add adjunctive therapy. Keep in mind that SSRIs can cause some jitteriness, which is uncomfortable for kids, some agitation in the first 10 days. So if you let people know that, they may stick with you better and stay with it. If you do augment, you can use clomipramine plus another SSRI, or you can use an SSRI plus risperidol at a low dose. And those things would be indicated if you have failed at least 2 different drugs used by themselves and used it in combination with cognitive behavioral therapy. So unfortunately, there's a pretty high relapse rate. 89% will relapse within 2 months if they're off treatment. So you want to keep it going a long time, probably a year to a year and a half. Relapse is reduced if you use cognitive behavioral therapy. And if there are compulsions, habit reversal training actually also helps with the compulsions in addition. Here's the dosing guide, and anybody who wants the slides, I can send them to everybody who signed into the call if you'd like, so you can have this stuff. We don't really know exactly how long kids should be treated, but if they do have those relapses, years of treatment is probably appropriate. So that's my slides. Now, here we go, 5 main types. So these are the 5 main types of symptoms of kids with OCD. One is about cleanliness, so germ phobia, right? One is about symmetry. If I do this, then I have to do that. One is about hoarding. One is about taboo thoughts, and those are often like thoughts of, I'm going to kill somebody, or that person has sexual designs on me, or something like that. And then fear of harm to self or often parents. So if you think about those 5 things, that would be a great place to start in asking about the kid's possible symptoms. Okay, so the Y box is not really a wonderful screening tool. It's more like helping to nail down the symptoms for yourself. But you may not pick up on this through just a pediatric symptom checklist, for example, unless it presents itself as anxiety or as oppositional behavior. So use your nose, sniff it out, and ask a few more questions about things the kid feels like they have to do or thoughts that they have over and over again as simple questions to get started looking for that.
Yeah, and it looks like those 5, the 5 kind of subtypes, actually, of OCD. And it's been interesting that they're actually, as they're now mapping out different genes, it looks like this is a collection of different kinds of disorders that have this in common. But it can look different, just like Barbara was talking about the ones with tics. Clearly, that's a different kind of genetic line. And some families may have a more predisposition for a particular manifestation of that. I like what you said about how common this is in preschool kids, so that even if the kid doesn't have OCD, you're telling us preschool kids are all a little
ritualistic
OCD, and tantrums could be getting in the way of their preconceived ideas about the way things should be. And that's an important thing to sort of be on your checklist, even if you don't come up with a diagnosis of OCD.
Right, because it can cause struggles with the family.
And the other thing that was really interesting about how normal some of these things are, and when if you guys are watching the NBA playoffs, the commentators were talking about among themselves, these ex-basketball players, Shaq and Charles Barkley, they say they all have rituals. They all have rituals. There was the guy who owns the free throw accuracy record in the NBA. This guy, Chris Jackson, his name was, also had tics, and in fact, you'll see when you watch them play that the good free throw shooters have using their OCD kind of habits, as well as the pathologists that you'll see in the hospital. But the being able to see the whole spectrum of this, and when it gets in the way, and when it helps. So
Right.
That's an interesting point.
Yeah, and it sounds a little bit like superstition to some extent too, that you want to fend off a defeat by doing this, wearing the same underwear. Right. Exactly.